All right, everyone, we're going to go ahead and get started.
All callers are muted.
I have Drew Preston here with us, the Communications Coordinator for Medicaid and Long Term Care. He is going to be doing a presentation for us, a basic level presentation, and as you may have heard me discussing, we are going to save all questions until the end. One, because I have everyone on mute as we are recording this presentation for anyone who could not attend so that I can put it on link for them to view at a later date. The only other housekeeping would be I just recently did a snippet of everyone that's on Skype. So if you are not logged into Skype, you will have to send me your attendance if you just called in via the phone. Or if you have other people attending with you, if you could also send me an email with their names and I will be sure that they get credit. And I might have already mentioned it, but the last thing is just that we are going to save questions for the end due to the recording. So with that, I'll turn it over to Drew.
Great. Well, thanks, Ashley. Can I borrow the mouse so I could?
You sure can.
Through.
Yes.
All right. Well, thank you everyone for joining us over the phone and on Skype. I'm going to give a high-level overview of Medicaid, both on, let's see if we'll use a keyboard instead of the mouse. Both on the federal level, overall what is Medicaid, and also we'll kind of delve into some of the particulars of Medicaid in Nebraska. So here we have our 5 topics of discussion today. We'll start with the history of Medicaid, kind of an overall overview of it. We'll then turn to the particulars of Medicaid eligibility in Nebraska. After that, we will spend some time discussing some of the different Medicaid programs in Nebraska. And the last 2 sections will be pretty brief, just kind of some administrative details on how we run Medicaid in Nebraska. Beginning with the history of Medicaid. Medicaid is a jointly administered state and federal program that assists low-income, disabled, and other vulnerable populations in obtaining health care. Medicaid is one of the largest expenses in the state of Nebraska's budget. It runs us about $2.1 billion a year. That's for fiscal year 2017. It's been relatively steady for the last few years, so it's largely the same for fiscal year 2018, which we are currently in. Funding for Medicaid comes from both state and federal sources. It's currently in Nebraska. Slightly over 50% is federal, and then slightly under 50% is state funds. So Medicaid was created in 1965 via amendments to the Social Security Act of 1935. It was created alongside Medicare, and those are the 2 titles of the Social Security Act. Title 18 is Medicare, and Title 19 is Medicaid. And these 2 programs are fairly commonly confused, one because their names are very similar, and 2 because they were created at the exact same time. Just to kind of differentiate those 2 before we move forward, Medicare is a program for primarily senior citizens. Almost everyone in the U.S. over the age of 65 is eligible for Medicare. That's something that happens automatically just because of your age. Medicaid, like I said, is more for low-income populations or other medically needy populations, and the eligibility requirements varies between states. There's a saying that if you know one state's Medicaid program, you only know one state's Medicaid program. They vary in every single state. And these are some statistics I pulled from CMS, which I will talk about in a little bit here, just to kind of give you the size of the different populations of Medicare and Medicaid. About 72 million Americans are on Medicaid as of January of this year, and about 56 on Medicare. Now there is a little bit of overlap between those 2 populations because it is possible that you are a senior citizen that might be low income and thus be eligible for both. So since the 60s, Medicaid has changed somewhat. There's been additional legislation created to change the program over the years. One of the biggest changes was the Children's Health Insurance Program. That was created in 1997. That's Title 21 of the Social Security Act. That provides health insurance, health coverage for low-income children. That would be a bracket, income bracket above Medicaid. So if Medicaid, for example, would be 100% of the federal poverty level, CHIP would be slightly above that, maybe 100% or 150%, 200%. Now those are just numbers I'm making up, just for an example's purpose. And one thing to know about CHIP is that in the state of Nebraska, we don't differentiate between Medicaid and CHIP. CHIP is just rolled into Medicaid services, unlike other states. Another important piece of legislation was the Patient Protection and Affordable Care Act in 2010. That increased federal funding to Medicaid and expanded the eligible population in the states that elected to do so. And here are some other important rules, governmental bodies, etc., to note about Medicaid. CMS, as I mentioned earlier, stands for the Centers for Medicare and Medicaid Services. It's the federal executive agency that oversees both those programs. It's located in Baltimore, Maryland, the main office. When we have to interact with CMS, we usually interact with the regional office, which is in Kansas City. Nebraska DHHS administers Medicaid in Nebraska because per the federal requirements, one single state agency has to be in charge of administering Medicaid in every state. Now, it doesn't necessarily have to be the Health and Human Services in every state, but it does have to be one particular body. And so Nebraska, it's here in DHHS. DHHS, we and MLTC, we manage funding, review policy, and make eligibility determinations, but we don't provide healthcare services. That's left to the healthcare providers, the professionals, out across the state. The state plan is an important document to know about Medicaid. Every state has a state plan. It's a contract between the state and CMS that allows the state to draw federal dollars to fund their Medicaid plan or Medicaid program. Every state has to have one, and quite frankly, it'd be almost impossible for any state to run a Medicaid program without federal dollars. So the state plan is one other important thing to know. It outlines the Medicaid services the state offers, the methods of delivery for those services, and other details. It's a very long, lengthy document, about 300 pages, I think, for Nebraska's. And of course, there are other federal and state rules that apply. We could spend hours talking about just the different rules that govern Medicaid. So that aside, here's a snapshot of who is on Medicaid in Nebraska. As of May 2018, there's about 244,900, so 245,000 people in Nebraska in Medicaid, which makes up about 12% of our population. Children make up the majority of our enrollees. You can see here on the pie chart, the dark blue and the reddish pink are just children, so about 2/3 of our enrollees are children. They're broken down into Medicaid and CHIP, as you can see there with those figures. And the rest, the last third, is broken into parents, adults, the aged, and the blind and disabled. So there's all the numbers there, and that's our most recent enrollment figures. Now we can turn to Medicaid eligibility, how we determine who gets to be on Medicaid. So there are both financial and non-financial requirements for being on Medicaid. Some of the non-financial ones that are most important are U.S. citizenship and residency. So to be able to get services from Nebraska Medicaid, you have to both be a U.S. citizen and be a resident of Nebraska. Being a U.S. resident, usually entails Social Security number and other documentation like that. Here's a quick snapshot of some eligible groups. These are not an exhaustive list, but low-income families, low-income senior citizens, children, pregnant women, disabled populations, most of which we covered on our last slide. So, as I said, there are both financial and non-financial requirements for being eligible for Medicaid. Most of the rules around medical need are set in laws. The aged, blind, and disabled are the clearest example of groups that are whose Medicaid eligibility is driven more by their medical need than their income. Income guidelines are based primarily around the federal poverty level, which does change every single year at the beginning of the year. And that's why we have staff in MLTC to verify these requirements, calculate those figures, and so on, because unlike the rules that govern medical need, the federal poverty level, it changing so often, we have to stay on top of that. So if there's someone who thinks that they might be eligible for Medicaid, they can visit Access Nebraska, which many people in Children and Family Services are familiar with. There are tools there that can ask questions to guide people towards applying or not. So you don't have to necessarily apply for Medicaid to know if you're eligible. There are tools there to determine that whether or not that is a good idea for someone who thinks that they might need Medicaid. So all of our Medicaid eligibility categories, and they're all listed there, they're all broken into primarily two categories, financial and non-financial. We like to refer to them as MAGI, which means modified gross adjusted income. That's a pretty technical way of saying whether or not income is the primary reason that you're eligible, or if there's a different primary reason why you're eligible. So MAGI programs, meaning primarily income-driven programs, include Medicaid, Children's Medicaid, CHIP, Parent and Caretaker Medicaid, pregnant women, and so on. And non-MAGI, meaning the more needs-driven, medically needs-driven groups, include the aged, blind, disabled, transitional medical assistance, the Women's Cancer Program, and so on. And this is also not an exhaustive list. There are other categories besides these, but these are all of the major ones and a few of the kind of smaller programs as well. And here again, just to repeat some of the primary eligibility requirements. So whether or not you're MAGI or non-MAGI, you need to have all these things, or we need to know information about, for example, your living arrangements to determine whether or not you're eligible for Medicaid. So as for what services are covered by Medicaid, again, certain services are required by federal law, and other services are optional for states to cover. Some of those optional services we can still use federal dollars to cover, but others might have to be entirely funded by states. So listed here are 4 examples of services that Nebraska Medicaid offers. There's a much longer list of this on our website. But physician services, just your normal doctor's visits, hospital services, ambulatory services, and dental services. Dental is an important one to note because dental is one that the federal government does not require us to cover, but it is a fairly major one of our programs, and we do elect to cover dental services as part of your Medicaid package. State Medicaid services, all of them, whether or not they are optional ones or federally required ones, must be equal to all Medicaid clients across the state in terms of both statewide-ness or geography, which means that they can't only be available to Medicaid clients in certain parts of the state, and benefits, which means that whichever Medicaid provider you go to, you need to be able to get the same services whether or not you're in the eastern part of the state or the western part of the state. And of course, in Nebraska, we do have, since the West is a little bit more spread out, we do still make a concerted effort to make sure that those services are still available to folks all over the state, whether or not you have to drive a little bit farther than someone who's in Omaha, for example. All right, our next section here will be some Medicaid programs that we have available in Nebraska. Some of these are kind of some of the eligibility categories that we already discussed. The first one we wanted to talk about is Children's Medicaid and CHIP. Like I said, we rolled CHIP into Medicaid eligibility. So you see here that the federal poverty level kind of limitation for Medicaid does change depending on the age of your child. It gets a little bit smaller as your child gets older. And then, as I was saying earlier, CHIP covers an income bracket higher than that. It's cut off at 213% of the federal poverty level. Okay, next category is pregnant women and parent and caretaker Medicaid. Like most of these, as I've said, you have to be a resident of Nebraska to receive these services. If you are trying to be eligible in the pregnant women category, you have to provide to Medicaid your due date. Pregnant women are covered after 60 days after their delivery, and your newborn is covered until his or her first birthday. For pregnant women, the cutoff is 194% of the federal poverty level. That's your annual income for all these, I should have mentioned. And for parent and caretaker relatives, the income limit is 58% of the federal poverty level, which is a little bit lower, but there are some other programs to help that population out, as I will explain in a little bit. Another program that we have is the 599 CHIP program. It's a program that's kind of similar to the pregnant women Medicaid eligibility category. It's for expecting mothers who are otherwise not eligible for Medicaid. The coverage is limited to only prenatal and pregnancy-related services, unlike the pregnant women category I talked about. The previous slide, that would be the full range of services offered to Medicaid clients, whereas the 599 CHIP program is really just related to pregnancy-related services. Eligible mothers cannot have other health insurance. And included here are two reasons why, just two common examples of how someone might end up eligible for the 599 CHIP program. Pregnant minors who have her parents' income may be too high so that she wouldn't be eligible for those services, or women who might not be eligible due to their immigration status. Another program, fairly small one, there's only about 400 or 500 people in this program currently in Nebraska, is the former foster care program. It's for people who are under the age of 26 who were receiving Medicare, or excuse me, even I mix up those two programs, Medicaid at age 18. At age 18 or 19, they had to have been in the care of the Nebraska foster care system or a Nebraska tribe. And they also can't otherwise be eligible for other Medicaid programs. So they can't be eligible another way to receive Medicaid through the former foster care program. But one great thing for this population, however small it is that they are exempt from income tests when applying for Medicaid. So really, if most people who apply for this program and meet the other two categories, they were on Medicaid at 18 and were in Nebraska foster care, they can get this program. Next program to mention is the Emergency Medical Services for Aliens, EMSA for short. It's for people in the state who are ineligible for Medicaid due to their citizenship status. They might be undocumented, for example. It covers only emergency medical treatment, and included here are some of the, in the state plan, I believe, the language that defines what emergency treatment is. So it's a serious jeopardy to their health, serious impairment of bodily functions, or bodily dysfunction, which are all fairly similar to each other. And like I said, it only covers hospitalization or emergency room, the labor and delivery of a baby, or very serious events like strokes and TIAs, really only for emergency situations. So someone would not be able to receive routine care through this program, really only if it's a pretty serious situation. And we've talked about this category quite a bit so far, the aged, blind, disabled. Aged for that category in Medicaid is the same as Medicare. It's age 65 or over. As for blind, it's anyone blind or disabled, who are receiving Social Security disability benefits. So the Social Security Administration, the federal body, will determine that they are blind or disabled, and then we follow their lead to make them also eligible for Medicaid. The income guidelines for all of these three groups is 100% of the federal poverty level. But for this group, one thing that's nice is that they can also have private health insurance on top of Medicaid, which is taken into account when we calculate their income and their eligibility. The resource limits for these groups are $4,000 if you're living alone, or $6,000 for a couple. Which means that if you have set aside over those two levels, you're likely not going to be eligible for Medicaid. The next two slides are some side programs. They aren't necessarily eligibility categories, but they are ways that people can be eligible for Medicaid. The first one is called share of cost. And share of costs is when Medicaid can cover some of your medical expenses, even if your income exceeds some of the other guidelines I've already mentioned. So it's when share of costs is when a client pays for a portion of the medical expenses, and then Medicaid pays for the rest. So you and Medicaid would be sharing the cost of your treatment. But to be eligible for share of cost, your income can be the only thing that makes you ineligible for Medicaid. So all other eligibility categories have to be met, besides your income. And it's worth noting that not just anyone will be eligible for share of cost either, because if your income is high enough, your share of cost would be 100% of your treatment, thus making you ineligible for this program. And resource spend down occurs when, if, for example, you have excess income or resources when you apply for Medicaid, which would make you ineligible, but you also have outstanding medical bills to pay, you can use those resources, your existing resources, to pay off that medical bill and then retroactively qualify you for Medicaid. An example of this would be that if you were $2,000 in resources over being eligible for Medicaid, but you had a $2,500 medical bill that was still outstanding, you can use that $2,000 that you have, pay down as much of that bill as you can, and at that point you would be eligible for Medicaid. So it's spending your resources down to be eligible. One of the last programs I want to talk about is the Transitional Medical Assistance Program. It helps parents and caretakers become self-sufficient and help them out, in maybe some trying times. Like I said, that 58% that I mentioned earlier is kind of low for that population. This program is one of the things that we have to help them out. You qualify for Transitional Medical Assistance, or TMA for short, if you would otherwise have been eligible for Medicaid in 3 of the last 6 months, besides income. But your income is still less than 185% of the federal poverty level. So for that year, Medicaid can help you with your medical expenses. And if you're on it for more than 6 months, you'll pay a monthly premium to stay in that. And we do have TMA clients do have to be employed to be eligible for that program. I believe that's one of the only Medicaid programs that we have that requires employment. So next I want to talk a little bit about how we deliver those services. Most of what I just talked about were eligibility categories, but it's also important to understand how these health services are actually being delivered to our members. So almost all Nebraskans on Medicaid are enrolled in a program, managed care program called Heritage Health. This program launched January 1st of last year. And to kind of illustrate what this is, managed care is a system by which the state contracts out with managed care organizations, or MCOs for short, which I'll be referring to them as. These MCOs coordinate all care for their members. In the Heritage Health program currently, this includes all physical health benefits that we offer, all behavioral health services that we offer, and all your pharmacy fills as well. So since January 1st of last year, we have 3 MCOs, which are kind of like, just think of them like as insurance plans that are available for Heritage Health members to choose from. That's United Healthcare Community Plan of Nebraska, WellCare of Nebraska, and Nebraska Total Care. So we have those 3 plans. 233,000 people are currently enrolled in Heritage Health because, like I said, that Heritage Health delivers almost all of our Medicaid services, so almost all Medicaid members are in that plan. Now there are some other services that are outside of Heritage Health, and that's why that total enrollment figure isn't the same as the one I mentioned last time. There's a little bit of a gap, but like I said, most Nebraskans on Medicaid are in Heritage Health, and you see here on this pie chart that they are distributed almost exactly evenly between the 3. I think there's a less than 2,000 plan or 2,000 member difference between the most enrolled and least enrolled. So fairly evenly distributed between our 3 MCOs in Heritage Health. So as I was kind of alluding to, the basic benefits of each of those 3 plans, we require them to be the same. So you're going to be able to get your same doctor's visits, your same checkups, pharmacy fills, same benefits on all 3 plans. But because they are private companies, they can offer some incentives, some side programs that might be a little bit different. Kind of like rewards for going to your checkup and small things like that. But like I said, the fundamental benefits are the same for all 3 plans. And how this works is that the state of Nebraska, Medicaid, we pay a monthly flat fee. The technical term is a capitation payment. We pay that per member to each of the MCOs. And then in turn, that company takes on the member and is responsible for making sure that they get the care they need, and they're also responsible for paying the providers. So it works in a very similar way to how maybe our insurance company works as far as making sure that people are paid. This structure is good because it promotes preventative care. It's in the long-term interest of the MCOs to make sure that people get preventative care, because that's been shown not only to, and most importantly, to promote better health outcomes. Preventative care in the long run is also cheaper too. So this structure promotes good health care for our Medicaid clients. And just some kind of funding details here. Heritage Health is the largest part of the state Medicaid budget. It's 1.2 of the 2.1 billion annually that we spend, so a little bit over half. And like I said, that some services that Nebraska Medicaid offers are not included in the scope of Heritage Health. Now, Heritage Health is the majority of those services, but there are some services outside of it. Dental, like I mentioned earlier, is one of those services. Non-emergency transportation, like driving just to your regular checkup, is not in Heritage Health. And also long-term care services, such as nursing facility care for the elderly. Things like this are services that Nebraska Medicaid offers, but are not inside of Heritage Health. And just to share a little bit about our dental program. We launched a managed care contract with MCNA, that stands for Managed Care of North America, on October 1st of 2017 to be Nebraska's dental benefits manager. So this works in a very similar way to Heritage Health, but it is only for dental. So think of, you can almost think of dental as kind of like Heritage Health, but smaller and more focused only on dental care. So MCNA works to deliver all of our dental benefits to Nebraska Medicaid clients in a similar way of managed care. Nebraska dentists can join the MCNA network and then deliver services to our Medicaid members. And MCNA handles all claims payments, prior authorizations for expensive treatments, and otherwise coordinates all dental care for Nebraska Medicaid. And we are approaching the conclusion here. I just wanted to share a little bit of information that many of you might be familiar with, but just kind of some of the technical details about how Nebraska administers Medicaid. So, as I mentioned earlier, Medicaid in Nebraska is administered only by the Division of Medicaid and Long Term Care here in DHHS. And as I'm sure many of you have worked with maybe someone from Medicaid in the past, our work does overlap with other divisions such as DD and CMS. And MLTC, as I mentioned, is primarily focused on administering Medicaid, but we also have other services that we offer too, like long-term care. Nursing facility care is not necessarily Medicaid, but it is a service that we offer. And structurally, we have five units: the State Unit on Aging, Operations, and Analytics. Analytics performs a lot of our data gathering, helps us analyze our performance of Heritage Health and our other services to make sure that we're doing the best that we can. Delivery Systems is where Heritage Health and Dental falls under, so that's the section that's primarily focused on actually making sure that our Medicaid members get the services that they need. Finance and Program Integrity Finance is fairly straightforward. They deal with funding the program. And program integrity is where healthcare providers can enroll with Nebraska Medicaid. Providers do have to join us to be able to offer Medicaid services out to clients. And finally, policy and communications. I am the communications half of that, and policy works with things like determining eligibility and they do state plan changes if we have to change that document, and other kind of rules-based things like that. And just a little bit of information on some upcoming projects that we are working on. These are primarily technology projects. We are in the process of replacing our Medicaid Management Information System, or the MMIS. These three are some projects that will replace the MMIS piece by piece. That system was built in the 1970s, so it's time to upgrade. The DMA is a project that I'm also involved with. It'll help to take in data from all the disparate sources that MLTC works with. They can help to organize it, help us perform better analysis of that data to improve health outcomes. The claims broker service, as I mentioned, how not all Medicaid services are in Heritage Health. This is a key piece of making sure that we can eventually transition all of our Medicaid clients into a managed care system. And finally, we have the EES, which CFS is involved with as well. It's building the back end for NTRAC, which will be the new system on the back end of Access Nebraska. So that is my presentation. I'd be happy to answer some questions now. If I don't know the answer to your question, maybe you can pull up that last slide. My email is there so that we can, if I don't know the answer to your question, I'd be certainly happy to fill an email and get you in touch with someone who might be able to answer that question.